Moving on to the next section, I cordially invite Professor Ajit Malrasekara, Dr. Vajira Mahesh to chair the session about vesico-vaginal fistula repair. Over to you, sir, to introduce the speaker.
So for the next speaker will be Dr. T. Aravinthan, consultant urological surgeon from the teaching hospital Kaluthara. Over to you, Aravinthan.
The vesico-vaginal fistula. What is new trends and reviews? The VVF is an abnormal opening between the bladder and the vagina that results in continuous unremitting urinary incontinence. The reported incidence of VVF is different between the developing and the developed countries. Similarly, the etiology also varies. The most common cause of VVF in developed countries is pelvic surgery. The incidence varies between 0.3% and 2%. The less common causes are radiation-induced and advanced pelvic malignancies, such as bladder, rectal, and the cervical tumor, and their treatment. In underdeveloped nations, the prolonged obstructed labor constitutes the most common etiology of VVF, more than 90%, especially in sub-Saharan African countries. There, the poor socioeconomic status, early marriage, malnourishment, low literacy rates, and the poor healthcare system contribute to the higher prevalence of VVF in these countries. So there are so many classifications in the VVF management. So VVF, mainly obstetrics, it is often classified by two systems, namely the GOC and the Waldick classification system. The Waldick classification system takes into account the involvement of closure mechanism, the involvement of external urethral meatus, extent of the defect. The GOC classifications consider the distance between the distal edge of the fistula to the external urethral meatus, extent of the fibrosis of the fistula, size of the fistula tracts. The Capes et al. Have demonstrated that the prediction of successful repair was significantly better with the GOX classification than the Waldick classification system. The VVF can also be classified as either simple or complex fistula. Any fistula which is solitary and is less than 0.5 centimeter in size is in a non-radiated and non-malignant situation is termed as simple fistula. Fistulas that are larger in size, more than 2.5 centimeter, multiple, have a history of failed previous fistula repairs associated with chronic infection and disease, post-radiation induced, associated with malignancy, termed as complex fistula. So what are the management options? So initially, we do conservative management methods. So continuous bladder irrigation, the continuous bladder drainage, the catheterization with fulguration of the fistula tract, fibrin glue injection, injection of PRP, the platelet-rich plasma, giving anticholinergics, all are practiced with various success rate. In intractable and recurrent VVF, we try the bilateral percutaneous nephrostomy. Even the large fistulas, we try the bilateral PCN with bilateral ureteric occlusion. So what is continuous bladder irrigation? It's useful for urine leak decreases with the indwelling catheter, and the fistula onset is less than 3 weeks. Fistula tract is long and narrow. The size of the fistula is less than 1 centimeter. Similarly, conservative management should not be advocated in complicated VVF. That is, the size is more than 3 centimeter. The fistula is secondary to the post-radiation induced damage to the urogenital tract. Extensive scarring around the fistula, and onset of fistula is more than 6 weeks. Overall success rate of CBD alone ranges between 3 to 32%. If the size of the fistula is less than 5 millimeter and the patient becomes dry after the catheter placement, the chance of healing with CBD is high. The fulguration of the fistula tract. The fulguration is performed when the fistula is small in size, recent in onset, has a long, narrow tract, and the fibrosis is absent. The Stokesky et al. Has reported the success rate of 73% with electrofulguration along with 2 weeks of CBD in patients with smaller fistulas, like less than 3.5 millimeter. Fibrin glue injection. Fibrin glue is used as an adjunct to the VVF repair. The glue is injected transvaginally under cystoscopic guidance after electrofulguration of the fistulous tract. The CBD is followed for about 4 weeks duration, and the fibrin glue helps to promote the fibrosis. Injection of plasma, the platelet-rich plasma. The PRP is injected around the fistula, occludes the fistula mechanically, and also it promotes the growth factors derived from the platelets, stimulate the fibrosis and neovascularization. Bilateral PCN and the ureteric occlusion. This is actually a palliative procedure in patients with malignant VVF. The smaller fistulas may heal with bilateral PCN, but for the larger fistulas, we have to do a bilateral PCN, this is a ureteric diversion, and same time we have to block the bilateral ureters with the isobutyl cyanoacrylate. Some people use balloons, nylon plugs, coils, vascular plugs, and gelatin sponges. Percutaneous urethrostomy and the urethral clipping are rarely performed. We don't do it nowadays. So when to operate? It's an early intervention or late. Usually the repair is performed at 12 weeks of duration after the diagnosis. Timing of repair is influenced by the nature of injury leading to the fistula, the nutritional status of the patient, presence of infection and foreign bodies, immunocompromised status. For post-obstetric fistulas, delaying the repair of an obstetric fistula ensures that the necrotic tissues would slough out and the inflammation would subside. If the fistula is simple and has no evidence of infection, an early repair can be performed. Post-surgical VVF, the ideal time is 12 weeks. Though this will allow the inflammatory changes to subside and the necrotic tissue to get delineated. But there are exceptions. The VVF confirmed within few days of primary causative surgery, associated with concomitant ureteric injury requiring intervention, and sometimes patient desire or compulsion of surgeon, so we do early intervention. So the urinary diversion after repair of VVF. The perurethral catheterization is most commonly followed. The concurrent suprapubic cystostomy is claimed to provide an additional safety when the urethral catheter malfunction. Few have preferred suprapubic diversion alone. Commonly, the catheter is removed by the 14th day, but may be kept longer depending on the number and size and nature of the fistula, and effectiveness of the repairs and expert of the surgeon. For radiation-induced fistulas, the radiation-induced reaction heals in about a year. So we have to delay the repair. So roughly they say around 6 months we can wait and do the repair. So what is the approach? It's a transabdominal or transvaginal. The choice of surgical approach depends on the familiarity of the approach of the surgeon, the location of the fistula, available space in the vaginal cavity, and need for ancillary procedures such as ureteric reimplantation and the feasibility of obtaining necessary interposition flap. The Hillary et al. Showed that the success rate was much higher for the transvaginal repair when compared to the transabdominal repair. And there are some studies have preferred the transvaginal route for simple fistulas and the transabdominal route for complex fistulas. So vaginal route has certain specific advantage. So it avoids the abdominal and bladder incision, lesser blood loss, option of interposition flaps are plenty, short operative time, shorter hospital stay, and a rapid recovery. So this approach is often used when the abdominal wall is scarred by previous surgeries. So vaginal route is contraindicated if there is a narrow scarred vagina, post-radiation fistulas, concomitant rectovaginal fistula. Abdominal route is preferred when the vaginal route is contraindicated. It's also often advocated if concomitant procedures such as ureteric reimplantation and augmentation cystoplasty are required. Presence of bladder stones, highly placed fistula with a narrow vagina. So how to position the patient? So it depends on the size and the location of the VVF. The amount of exposure required for repair, experience of the operating surgeon. The Lawson and jackknife positions are ideal for proximal urethral and bladder neck fistula. The dorsal high lithotomy position with a steep Trendelenburg positions give excellent view for the repair of high VVF and is also used during the laparoscopic and robotic VVF repairs. The traditional SIMS position, we don't use it nowadays. Almost all the cases of obstetric VVF can be performed in lithotomy position with head down. So what is a technical modification? Classically, what we do is the bivalving the bladder to repair the fistula as described by O'Connor and Sokol. It was a standard practice. But this approach is questioned by newer techniques and the recent techniques. This include limited vertical cystostomy, horizontal cystostomy, intravesical repair of VVF. So supratrigonal VVF repair by a modified O'Connor's technique. So what they found is decreasing the operating time, improve the ease of the suturing, and decrease the incidence of overacting bladder and help in early anterior dissection, which reduces the tension on the suture line. So what about the interposition tissues, so flaps? To improve the healing and reduce the chance of recurrences. The number of flaps have been described for both transabdominal and the transvaginal VVF repair. Peritoneum, omentum, gluteus muscles, rectus abdominis muscles, gracilis muscles, small intestinal muscles, submucosa, human dura graft, sigmoid epipola, urachus, and some other tissues are described for interposition. The retrospective analysis of 26 patients undergoing transabdominal VVF repair with omental or peritoneal flap interposition, the 16 of which had complex VVF has been reported. The 100% success rate with a maximum follow of 73 months. Interposition flaps are not routinely utilized when the surrounding tissues appear healthy and well vascularized, such as in a benign etiology. Tissue interposition should be considered whenever the closure lines or the vaginal tissues are questionable quality. And when you talk about the muscle flaps, they say the adjacent muscle flaps have a better success rate than the bulbocavernosus flap because of the vascularity of the bulbocavernosus muscles may be compromised by the previous radiation. So what is the approach? Is open or laparoscopic or robotic? Traditionally, the VVFs are repaired via the transabdominal or transvaginal approach. The laparoscopic repair of VVF requires a high level of surgical skills, especially during the dissection and the intracorporeal suturing. The advent of surgical robot has made this demanding task easy. Two approaches have been described. One thing, you can do transperitoneal transvesical or transperitoneal extravesical. There's limited studies are available to compare the outcome of open, laparoscopic, and robotic method of VVF repair. With the improvement of minimally invasive surgery, open transabdominal repair of VVF may be obsolete. But still, the transvaginal repair should be the gold standard wherever possible. So what is the suture material we use? Traditionally, the VVS is repaired with absorbable sutures such as polycollecting and similar ones. The laparoscopic robotics, the rapid and precise suture has become important. So they use the V-lock or S-fix are being frequently used to improve the suturing maneuvers and reduce operating time. So what about the cystogram before catheter removal? The cystogram helps to assess the integrity of the repairs and decide on the time of the catheter removal. Time of catheter removal following VVF repair also varies from 2 to 4 weeks. There is no recommendation on when to perform cystogram after VVF repair, as most of the surgeons prefer catheter removal after confirming the absence of leak on filling cystogram. So cystogram should be performed under dynamic fluoroscopy to avoid the inadvertent complications. So there are some outcomes, complication, so the morbidity of VVF repair. One is the overacting bladder. Because the overacting bladder and acute spasmodic arising from the bladder is an important problem that need to be tackled during the post-operative period. The highest incidence reported in Volt fistula, followed by the Vesico uterine fistula. The abdominal approach essentially requires the bladder splitting and result in a high incidence of bladder spasm. Patient post-VVF repair will have continuous bladder drainage for few weeks, which is one of the non-modifiable factor causing bladder spasm. So we manage with the anticholinergics to reduce the discomfort. Will you do the routine biopsy? The routine biopsy is not recommended, and an individually tailored approach would be helpful to avoid undue complications secondary to the biopsy. So we don't recommend. And the stress incontinence and after VVF, because it's because of the ischemia and the iatrogenic injury to the supports of the urethra, either from the inciting or from the surgical trauma. So placement of mid-urethral sling during the primary repair of VVF is controversial. And Vesico VVF repair and the sexual outcome, because the vaginal length is decreased on an average of by 5 millimeter following surgery. Larger size fistula is more than 3 centimeter, and reduced vaginal caliber were associated with a higher risk of post-operative sexual function. 30% of patients were, yeah, we'll give you 1 minute.
Thank you.
It's the last slide. 30% of patients were waiting for doctor's permission to resume intercourse even after 6 months of surgery. So intercourse is usually prohibited for a period of 3 to 6 months. However, the recent studies have shown that the sexual activities can be resumed as early as 6 weeks. Adequate foreplay, avoiding rough sex, and intercourse during the menstruations are gentle post-operative advice given to this patient. Thank you.
Thank you, Dr. Aravinthan, for that resourceful lecture. As a small token of appreciation,